Thank you. Good morning, everyone. I want to start by outlaying some facts. In Australia, between 1980 and 2011, the age standardised rates of obesity-related diabetes more than quadrupled. What and how we eat today is actually the leading contributor to global greenhouse gases, contributing some 32%, and yet it's something we often fail to recognise or talk about. In 2015, 2 billion people on this planet are either overweight or obese, and almost 800 million continue to go hungry. Our urban and food environments actively discourage active transport and drive consumption, yet obesity is still framed as a political issue and as an epidemic driven by laziness. We have a Royal Children's Hospital here in Melbourne that has a McDonald's inside its premises in a time when 1 in 4 of our children are overweight or obese, and questioning the appropriateness of this brings calls of the nanny state. Last year, summer was brought to us by McDonald's, Joyville was brought to us by Cadbury, and our happiness came courtesy, printed with our name on their bottles, by Coca-Cola. And finally, unlike the mosquito or the major problems of last century, our biggest health threats this century have powerful lobbies and are happy to sue governments and populations who act to protect themselves. In short, we have an overwhelming burden of preventable chronic disease. We have a healthcare system designed for last century's problems, and we have a lack of coordinated, powerful voices to steward change and set a new public health rhetoric. So they're the facts. Now let's look at the problem in a little bit more detail. Margaret Chan famously says, "These diseases that I'm about to talk about are a slow-motion disaster, as they take some years, if not decades, to develop and kill. But countries like Australia do have a highly visible warning signal that bad trouble is on its way in the form of population-wide obesity, an issue that no country in the world has been able to curb or reverse." In short, and probably somewhat controversially for 9 o'clock on a Monday morning, I would argue we have built human systems in 2015 that are causing disease. Food systems, economic systems, and urban systems. What diseases am I talking about? I'm talking about non-communicable diseases. This is the 4x4 table famously developed by the World Health Organization. We look at 4 diseases and 4 modifiable risk factors that they share. So cardiovascular disease, diabetes, cancer, and chronic lung diseases that are caused across all 4 by tobacco use, unhealthy diets, physical inactivity, and the harmful use of alcohol. Now, you could also include mental health here, but politicians are simple minds, and back when they developed this 4x4 table, they decided a 4x4 was easier than a 5x4 to remember. A little joke, but in part somewhat serious. What's important, though, to take away from that 4x4 table is that these are 4 diseases that share similar determinants and therefore share mitigation and prevention opportunities. If we act on one shared modifiable risk factor, we can make enormous gains, as we have done with tobacco, for example, across all 4 and even more diseases. This is some data from the International Health Metrics and Evaluation Group, Chris Murray and his group from Seattle in Washington, the US, and it's the global burden of disease data for Australia. This ranks the top 17 causes of disability-adjusted life years, so lost years of life plus years of life to disability. And these look at the risk factors, the top risk factors here in Australia: diet, blood pressure, tobacco, alcohol. Do they sound familiar? In 2013, very similar. High body mass index, obesity and overweightedness, dietary risks, tobacco smoke, and high systolic blood pressure. If we look at how this then translates into disease, again, disability-adjusted life years, years of life lost plus years of life to disability, same group and same representative graph. We look at 1990 to 2000. Again, what you see, the leading causes are, of course, chronic preventable disease. So where has this epidemic come from? Well, there are a few places in short. It hasn't come overnight, but we have got this epidemic of preventable disease, and where has it in fact come from? Well, it's important to acknowledge that in part it's because we did a very good job at public health in the 20th century. Largely, unfortunately, not doctors. It was urban planners, engineers, and a few billionaires. But we did make enormous gains on what were the 20th century challenges of water and sanitation, maternal childcare, and mass vaccination. At the same time, 11% of the global population is now over 60. By 2050, this will be 22%, and we're going from a world of around 7 to 10 billion people. So we're going to add another 1.3 billion approximately over the age of 60. Simultaneously, for the first time in history, more than 50% of the global population now lives in cities. This has never been the case. We have a globalized, we've seen the globalization, the commodification, the increasing processed nature, and the homogenization of our global food system. More and more of the world eats the same diet, and unfortunately it's not a diet that we should be or wanting to be eating. And lastly, there's a long lead time between risk and exposure to disease outcome. No one knows it better than you guys. There's a long period in there where politicians, societies, and science can sort of turn a blind eye. So where are we in 2015 in Australia? Well, these diseases are the leading causes of death. They cause about 35, so we have about 35% of Australians currently living with one of those diseases, and 2%, or around 1 in 50, have 4 or more. Preventable disease causes about 91% of deaths here in Australia, and the top 3 alone contribute around 18% of all GP visits and 30% of health expenditure. And we also know that these diseases, for example, cardiovascular disease is 40% higher in the lowest socioeconomic groups as compared to the highest. But unfortunately, it's not just a problem for Australia, it's also a problem for the world, and this is where I focus my work. So I understand that at 9 a.m. on a Monday morning, epidemiology is not everyone's cup of tea, unless you're a bit of an epi nerd like myself. So I don't want you to necessarily look at the detail in these graphs, but I want you to look at the general trends. This shows infant and young child overweightedness from 1990 to 2015 divided by World Bank groups, so low income to high income countries. And the take-home message here is no one is avoiding a rising epidemic of childhood obesity. Whether the poorest countries or the richest countries, obesity in children is going up. Here again, age-standardized prevalence of overweightedness, this time in adults, aged 20 and above. First divided by the WHO regions, and second divided by World Income Group by the World Bank. And the take-home message here is, again, you might expect that as income goes up, there's a linear relationship with overweightedness and obesity. And frighteningly, that's actually not the case. The highest rates of obesity and overweightedness we see in the upper middle income countries of the world, some would argue far less able to cope than Australia with what is a growing epidemic. And this looks at age-standardized rates of diabetes in adults aged 25 and above, and again the same disaggregations. So we have region and income group. And again, I just want to sort of blur your eyes and look at the graph. There are 2 take-home messages. First of all, actually it's not America or Europe that has the highest rates of diabetes, prevalence of diabetes in the world. It's in fact the Middle East regions, and that it's not the highest income countries that have the highest rates of diabetes in the world. It's in fact the upper middle income countries, and the lower middle income countries are not actually very far behind. So what are the take-home messages on NCDs, non-communicable diseases? If you remember nothing else from this talk, I just want you to remember 6 things. First of all, these are not a group of diseases of tomorrow. These are already the leading causes of global deaths. Approximately 2 in 3 people around the planet today die from one of these 4 diseases. These are not just diseases of the rich either. 85% of NCDs occur in the poorest populations. And diseases like diabetes, heart disease, chronic debilitating diseases don't just cause aren't just caused by poverty, but they cause and entrench poverty in return. And in this sense, we think of NCDs as a poverty cycle catalyst, not just around the world, but also here in Australia. What do I mean by this? Well, the WHO has done some great work, and we see here, and this is something to maybe have a look at later, but you see poverty at the household level feeds into poverty at the national level, a barrier to social and economic development. Low and middle income countries are increasingly exposed to common modifiable risk factors such as unhealthy diets, physical inactivity, tobacco use, and alcohol. And this is because of globalisation, urbanisation, and population ageing that we talked about before. These lead to non-communicable diseases, but they also directly lead to a loss of household income from unhealthy behaviours. They're expensive. Non-communicable diseases themselves lead to a loss of household income from poor physical status and premature death. And finally, limited access to effective and equitable healthcare services, arguably even here in Australia for the poorest, lead to a loss of household income due to high economic cost of healthcare, whether that's healthcare directly or the time and expenses of getting to healthcare and seeking healthcare. And all of this leads back to poverty at the household level, and if we've got enough people, then poverty at a population level or a barrier to economic development. And this is what we see. So output losses will speed up over time. And again, here we're looking at all the different income groups around the world, from highest income to lowest income, and orange is the world total. And we're seeing a dramatic, even possibly exponential increase in the losses, the economic losses due to these diseases worldwide. Number 3 is that these are not just diseases of the aged. More than 50% of NCDs globally occur in people under the age of 70. And you're probably a group that is seeing this every day in your practice, these diseases affecting younger and younger populations. They're also not just a group of diseases that affect men. In fact, Helen Clark, former Prime Minister of New Zealand and head of the United Nations Development Programme, famously says that NCDs now pose the single biggest threat to female health and development, causing about 65% of deaths worldwide. We also need to think about the intergenerational burden that these diseases hold. If you think about, you have a household, the head of the household, let's assume for simplicity it's a male, the breadwinner in a lower middle income country or even in Australia. They contract diabetes due to a number of different factors. Diabetes itself costs about 75% of a household income in Vietnam or Malawi, for example, to treat. But also suddenly the breadwinner is taken out of economic opportunity. That breadwinner now needs long-term care, regular follow-up, someone to help them as their vision becomes poorer, as they have problems feeling or walking. And who tends to be the first person to drop out of school or employment opportunities to take care of that person? Usually young females. And usually that burden is 10, 15 or 20 years or longer. And this is a real issue for the development, all of the enormous gains that we've made in female education and employment and social and economic development over the last 20 years. And here again, I don't need you to look at the detail, but what I want you to see is, first of all, that the enormous spike in the lower middle income countries is a burden of non-communicable diseases. Now, many of you will say, well, hang on, Alessandro, for those of you who have had your coffee this morning, you'll say, hang on, Sandro, that's where most of the world's population lives. Of course, that's where most of the diseases are. And to that I would say, exactly. But also, if you look proportionately, the red bar is NCDs, and even in lower middle income groups, the red bar proportionate to injuries and communicable diseases is still much larger. This is a really important one here in Australia. These diseases, diabetes, heart disease, obesity, these are not diseases of laziness. These are diseases deeply rooted in the social determinants of health. The opportunities in environments that we are afforded, that we are born into, that we grow, that we educate, that we are employed in, that we age and eventually die. This is the percentage of individuals suffering from heart disease within different household incomes here in Australia. And you see heart disease, very clear relationship between heart disease and income group. This is cancer. This is depression. And this is diabetes. Again, very clear relationships with income. and all of the confounders that come with that. But finally, before you get depressed, these diseases can be averted, and 80% of diabetes and heart disease and a third of cancers globally can be avoided. And we have the technology and the skills. It's a matter of now putting it into action. So as we move from the problems to the solutions, what are the solutions? Well, first of all, we need to remember that responding to NCDs, it's not a technical issue, it's a political issue. We have most of the cost-effective solutions, and it's now about translating the evidence to the policy into practice, and the practice into new norms. And also going up against the common challenges of calls of nanny state, the prevailing thought that it's based on and caused by laziness, or finally that NCDs are too complex to tackle. Because solutions do in fact lie everywhere in our economic system, food system, health system, education system, urban planning systems, and also in need for future research. So what are some of those solutions? We've talked about it a lot already, but there's a fundamental mismatch between the healthcare system we have in Australia today and the burden of disease that we face. 70 to 76% of Australian deaths are currently avoidable. Now, sadly, this doesn't mean we can live forever, but it does mean that people are dying earlier than they need to from diseases that are avoidable. At the same time, Australia spends only about 2%, actually less now, of 9% of GDP or recurrent health expenditure on prevention and public health. We like to compare ourselves to our friends over the Tasman or on the other side of the Pacific, and we're actually not doing that well. New Zealand spends about 6% and the US spends at least 3%. We need to start supporting progressive pricing policies and ensure that all communities have access to affordable, healthy food. It's not about a tax, it's about actually building in the true cost of the food that we eat. If we eat something that causes disease, if we know that, for example, soft drink is clearly linked to a number of disease outcomes, including obesity and overweightedness, and yet we don't build in the cost at sale to society. So we buy the Coke and it's actually cheaper than it should be or than it actually is to society. It's not about a tax, it's about actually building in the true cost of these products. The war on tobacco is definitely not won. We're being challenged in courts around the world, and as we are doing better and better, leading the world, in fact, they're moving, the large tobacco companies are moving their focus to low and middle income countries. We need to put systematic policies in place to increase food literacy in Australians. In 2 generations, we've largely lost our connection, our understanding, our ability to use and cook and consume healthy food and understand food. And this needs to be something that we as a population address. We need to strengthen and build the value of primary care as a platform for delivering prevention. The only healthcare system we can afford in the future is one based squarely around best quality primary care. And flowing on from this, we need to champion opportunities for prevention, for early diagnosis and for counselling aimed at behavioural change and health literacy, particularly in your care. We need to be catching these diseases earlier. We need to be having systems in place that stop populations from getting to the point that they need treatment rather than treating the disease once it manifests. And finally, this is probably getting a little bit beyond what many of you see as the scope of your mandate, but many of the biggest 20th century public health problems were solved through urban planning, through rethinking of urban planning. In fact, so were the 18th and 19th century challenges, and the 21st century challenges will be very much solved in the same way, rethinking how we live, the way in which we live, the way in which we design cities. It's extremely important, and doctors need to be more involved in these discussions. So finally, we've been through the facts, we've been through the problems, we've looked at some of the solutions, and now what is the role of general practice? Well, I would argue if you look at the evidence, if you look at the global policies, your role is really key. You hold the key to unpacking and solving this global epidemic here in the Australian context. If we look here at the set of 9 voluntary global NCD targets set by the WHO and the World Health Assembly for 2025, if you look at those 9 voluntary targets, there's not one that doesn't rest on your shoulders, sadly or luckily. Reducing alcohol, promoting physical activity, salt reduction, tobacco use, blood pressure, diabetes, these are all primary care focused interventions. You guys hold the key to halting or at least slowing the epidemic of NCDs. So I would argue you are not the first line of healthcare, but you must be the centre point and continue to be the centre point. So first of all, we need to reframe this issue and the debate, because public health is not winning alone. And I learnt this morning that you're 30,000, not 28,000, so I apologise. But as 30,000 powerful individuals, you are probably one of the most influential political voices, political groups in the country. When doctors speak, people listen. And as a group that has only the best intentions of your patients at heart, I think that you have an incredible opportunity and a powerful position to influence policy and to reframe this misunderstood issue. These are not diseases of laziness. These are diseases of social inequality, and these are neglected issues that we need to face. No one currently owns the prevention space. Public health cannot do it alone, and I think that primary care, general practice, has to really own the space of prevention. Stand up and sort of say, prevention is going to be something we are going to lead. 2% is inappropriate when the vast majority of Australians die of preventable disease. We cannot continue having a tertiary healthcare-focused health system going into the future. It doesn't make sense. It doesn't do our patients the justice, and in 30, 50 years, it's simply going to be unaffordable. This was from the National Centre for Social and Economic Modelling, and they looked at what benefits we would find in society if we actually made meaningful action across a few different strategic areas in the social determinants of health. 500,000 Australians would avoid chronic illness. 170,000 extra Australians would enter the workforce, generating approximately $8 billion in extra earnings. An annual saving of $4 billion in welfare. 60,000 fewer would be admitted to hospital, and 5.5 million would need to seek fewer medical services. Looking forward into the coming decades, we face a very different burden from that which we've faced for the last 100 years. As I said, 2% of the population now live with 4 of these diseases, and the vast majority of Australians live with at least 1. Multi-morbid, preventable, lifelong and complex, these diseases are going to take a new political voice, a new political will, and a strong push from general practice to see political action. General practice must be at the centre of a new healthcare system and must champion its realisation. Thank you.
Thank you, Alessandro. Michael Fasher, Western Sydney. From my point of view, I contend a big hole in the challenge, and that is improving the nurture of children in early childhood. It is clearly correlated. Adverse early child experience is clearly correlated with every risk factor and every outcome you mentioned. It is the early intervention and primary prevention that's required.
I'll take that as a comment. I agree.
Thank you, Michael.
I'm Charlotte Hesby. I'm a GP in Sydney. Thank you for your fantastic presentation. One of the areas of work that I'm really interested in doing is how do we engage GPs in understanding their role in population health. The system that we currently work in, as you say, was designed last century. It's a reactive model, and there's very little reward, and not for actually doing that preventive promotional healthcare. One of the things I would sort of like to address is how do we educate our doctors about changing the way in which they actually practice medicine? Because until we sort of get that, I think we're still stuck in reactive care models. Sort of like, even my registrars coming through don't get the power of data that actually even being able to put the data of the individual patient allows them then to look at their population and then to put that population into the picture of their general geography, and that through that we have huge power of being able to sort of understand the extra gaps of where people are actually needing it, so we can actually bring it to government and actually sort of bring about some policy change. But it's just brilliant hearing the work you're doing. Thank you.
Thank you. Well, as an epidemiologist, I wholeheartedly agree. I think, how do you change it? Well, I'm probably not the best person to answer that for Australian GPs. You're the best person to answer that. But I think it certainly comes back to medical education, the question of how we teach epidemiology and public health in the education at universities for medical graduates. Also in the training programs. I think then it comes back to senior, as always, I've always had very strong mentors in my life and now mentor others. I think it's been mentioned a few times, so having those conversations with your own registrars and making sure that it's part of the teaching that you provide. Convening such as this and having discussions like this at convening such as this. So I commend the RACGP for having me to come and speak. I think it's great to see Ncds and sort of the public health perspective as a keynote. And finally, as a college, as I said, I mean, for me, there's such not untapped, but partially tapped potential in the platform of your college, of 30,000, of just the group of general practitioners in Australia. When you talk about health, whether it's to the media or whether it's to your constituents or whether it's to your community or whether it's over a dinner, in a dinner party, when doctors talk about health, when doctors talk about the social determinants of health, people listen. And I think that's very easy to forget as we surround ourselves by doctors and as we kind of move further and further into our careers, the power, in fact, that we hold in society to have these discussions and to hold governments accountable and to bring these discussions, start these conversations in society. So, I think it's partly in the education system, it's partly in convenings like this, and I think it's also partly as a group, as a unified group of GPs and a strong political voice.
Hi, Hilton Coppy from Lennox Head. It's a small town on the north coast of New South Wales. I thought I might just tell you a story about one of my patients. I've been a GP in the area for about 25 years. Aileen, I don't think she'll mind me telling you, I've known her for nearly 25 years, and I like to think I've been a good doctor and looked after all her risk factors, blood pressure, cholesterol, sugar, all those sort of things, not smoking, activity. She's now about 84. She's had both the cataracts done. She's had every joint that could be replaced. She's now living in assisted living. She's starting to get dementia. She's got osteoporosis. So, I've done a great job at keeping her alive. She's pretty happy to be alive, and it may well be that this is a first world middle class question or problem. And, I fully accept everything that you say, but there's a cost for doing a good job. And I think Aileen's an example of that cost. And I guess I'm just interested in your comment on that, and also with regard to the economic modelling about if we're successful, there will be other costs associated with it. I'm not saying don't do it, but there are other costs if we do a really good job.
I'm not sure quite how to answer the question, because I think, there's no... you can't give poorer care so that people don't live longer. I think, what we need to do is give the best quality care to keep people as healthy as possible. And then if you have a short, quick death at 90 or 100 or 110, then that's probably the best outcome you can hope for. Having said that, we also need to keep in mind that as the population ages, and sure, there might be a period of, and individual patients that we can sort of bring to mind, but when we look at the population level data, people are staying healthy generally longer, much longer these days, and are able to contribute economically much longer. I know many people who are continuing to work much longer into their 60s. Retirement is later. That has enormous economic gains for society. And we often talk about the fact that there's an aging population, which is something we're going to need to tackle, but obviously compromising care to, there's not much we can comment on in that space. But I think we also need to keep in mind that as populations age, they're also able to contribute economically to society through direct and indirect economic gains for much, much longer. And that's an enormous economic opportunity. It's not just the economic stress or threat of people living longer. It's kind of a balance of both. I think the aim has to be to keep people as healthy for as long as possible, and that's, in my mind, the end of the discussion. But as a GP, I acknowledge it's probably more complex.
Thank you, Alex. Look, put your hands together for Alex. Thank you very much.
Thank you. Thanks, Frank.